Good morning, everyone. For those of you who don't know me, my name is Jill Gabbert. I'm an occupational therapist, and I've been with GoodCare since the beginning, so about 11 years ago. And we are just happy to be partnering with you and serving your residents here. I'm also president of GoodCare at Home Rehab. I'm not sure if any of you know about that company, but that's a sister company to GoodCare, and we provide outpatient therapy in people's homes. So do a little bit of both. So I'm here today to talk to you about our residents with dementia. A couple years ago, I became a certified dementia care capable instructor. And so some of what you're going to see today is just part of that. There's a 6-hour course that I teach from time to time. So part of what I'm going to talk to you about today comes from that course, and part of it comes from Tifa Snow. If any of you have ever heard of her, she's kind of a guru on dementia. So we're going to have a little bit of class time, and we're going to have a little bit of fun and interactive time too. So if you have any questions while I'm talking, feel free to just ask. Okay. So before we get started in talking about some of the stages of dementia, talking about communication and behaviors and things that really apply to your day-to-day interactions with your residents, we need to talk about dementia. So if you don't know a lot about dementia, dementia itself is not a diagnosis. Something causes dementia, either Alzheimer's disease, Lewy body's disease. Dementia is really just a description of the symptoms. Dementia is progressive, meaning it is going to get worse. It is not reversible. There's nothing that we can do to stop it. We can try to slow the changes that are happening in someone's brain with maybe medication, and I'm going to talk today about how we all can be the treatment for our residents with people with dementia, but we cannot stop it. So it's something that we have to help them live with and hopefully live well with. Okay, so I'm going to go to some slides here that I think will really give you a good idea of kind of what's going on in someone's brain that has dementia. So these slides up here is a PET scan, and it shows the activity in the brain. So if you look on the left side here, it's showing a normal or a typical brain and kind of what's going on there. Then it starts to show, moving to the right, someone with early stages of dementia. And you can see the colors are starting to change, meaning the activity is starting to decrease. The connections that are happening all within the brain are starting to decrease. Then the next one over is late dementia. You can see the red and the yellow, which is the really high level of activity going on in the brain, has significantly decreased. Now, why would we have a comparison to a child on here? Do you see the similarities between a child and someone with late-stage dementia? Okay. So I'm going to talk about that, but the first thing I want to say, and I have to say this every year, so if you've heard me speak before, we don't ever want to compare our residents to children, ever. They deserve our respect. They've lived a long, very productive, wonderful life, so we don't want to treat them like children, we don't want to talk to them like children, but we need to understand that their brain is actually kind of moving in a reverse type pattern. So when we do communicate with our residents, we do need to communicate differently, as in we would communicate with a child, but not childlike. Okay, we'll get to that in a little bit more later. But so do you see how the activity with someone with late-stage dementia and a child are pretty similar? That light blue, what that really means, it's kind of like the keys in the ignition, but the engine just can't get going. You kind of know, I'm here, there's people around, I just don't know what you want me to do, and how do I do that? Think about a child. So this child here is actually about 18 months old. So think about a child. They know you're around, they know that, maybe we're in a big crowd, or we're at home, or we're sitting and eating, but maybe they don't exactly know how to get the task done. That happens a lot with our residents with late-stage dementia. So hopefully that gives you a good visual picture of the changes that are happening with our residents. A few more slides here. So that's an actual brain, just to kind of give you you, again, a visual picture of the actual changes that are occurring. I'm not going to spend a ton of time here, but this is just kind of cross-secting the brain and just showing, you can see the difference between the top and the bottom section. The hippocampus, told you we were going to class today. The hippocampus is a part of your brain, and that part of your brain is in charge of memory, and it's a part of what we call the limbic system, which has to do with emotions. And so those memories and emotions are very strongly tied together, right? If you go to Grandma's house and she's cooking, right, that brings up a bunch of memories from your childhood. Or if you smell something baking that smells like something Grandma would have made, that brings a lot of memories to your mind. Same thing for our residents. So memory and emotion are tied together. But do you see how there's a lot of atrophy, a lot of shrinkage, and a lot of changes happening in that area? Again, there's the language system circled by the green. So when our residents are having trouble figuring out the words they want to say or understanding the words that you're saying, this is what is happening. This is what's happened in their brain. There's a physiological reason for that. Hearing, not so much change. You can see the green circles there. Here's also significant changes. This is what we call kind of our sensory motor, again, language center, just figuring out where am I at, what am I supposed to do, how does that feel, just making those connections. Significant changes are happening. And then vision. You can see how the vision area has also shrunken down and decreased. Okay, so there's lots of changes going on in the brain of our residents, and I think it's really important that I show you these slides. I think it gives us empathy. I think it gives us understanding. I think it helps us to know that sometimes what they do, they don't mean it. You know, they can't, there's not a filter there. There's not a, if I do this, I'm gonna hurt this person, or if I do this, that might hurt that person's feelings. There's a reason for that. And so it's our jobs as caregivers to really try to not take those things personally and try to work through that so we can decrease some of those instances that are happening. Okay, I'm gonna switch slides here. So now I also want to talk to you about stages of dementia. So therapists, OTs in particular, we talk about stages of dementia as 6. We've got 6 different stages that we assess and put them in. Most of the time, doctors, nurses, you guys talk in terms of usually 3 to maybe 4 stages, early, middle, late, and maybe end stage. The OT stages you don't need to be aware of, but sometimes we look at some of the middle stage can have a huge variation, as well as the late stage. So we kind of break it down into early, late, late, those kinds of things. But we're going to talk about, trying to simplify it a little bit, we're going to talk about early, middle, late, and end stage. So I'm actually going backwards here on these slides. But so with our residents with end stage dementia, so some of this, again, like I said, is part of a class, so I'm not going to go into every little part. But so with our residents with end-stage dementia, what is left, what is remaining in their abilities are some of those automatic actions, like swallowing, breathing, pain response, some of those real primitive type abilities. The developmental age comparison here, and again, I caution you like I did before, this is just for our learning. The developmental age comparison here would be like an infant. So when you have a resident with end-stage dementia, and they're probably in a jerry chair, and you're completely feeding them, and you're completely caring for them, that would be like an infant, right? But an infant can still feel pain, an infant can still feel love, an infant can still interact with you, right? Making eye contact with you, maybe smiling, enjoying themselves. So remember that when we have residents in that end-stage dementia, they still can feel and enjoy certain things. So it's our job as caregivers to find that and help them to do that. Primary remaining abilities, I kind of mentioned here already. There's a minimal response to sensory stimulation. So if someone comes and gives them a shot, they might just kind of wince a little bit, where you and I might go, oh, that hurt. You know, there's a stronger response that we would have than someone else would have. If, you know, they have sores on their bottom, you might not even know until you see it, because they're not vocalizing the pain. So just be aware that our residents with end-stage dementia have a minimal response to sensory stimulation. So we have to really be observant as to even just the smallest little sign of pain or discomfort. As I said, they're still able to swallow, vocalize, and maybe some partial range of motion. So they're starting to get a little tighter. It's a little harder to move their body. That's where it's good to do that range of motion and keep them as loose as possible. That also helps with pain. Late stage dementia. Developmental age comparison here is 12 to 18 months, and we're going to see why here in just a minute. In late stage, they're still able to maybe walk, stand, some simple communication like yes and no, and possible, you know, feeding themselves with maybe a spoon and a cup, or maybe just some finger foods. That's kind of what's going on in this stage. So like a 12 to 18-month-old child, right, you see some of the same similarities. But when you talk to a 12 to 18-month-old child, we also use simpler words, simpler phrases. So our residents in this late stage, we need to do that, again, not talking to them like children, but using shorter sentences, shorter phrases in how you communicate with them, because they will understand that better. Middle stage, developmental age comparison here is 18 months to 3 years. And this one, if you remember anything, this is the busy stage. This is where you're finding things for them to do, or they'll find things for them to do on their own. They're very, very busy here. So primary remaining abilities are they can still grasp objects, they have eye-hand coordination, they can participate in simple activities, can feed themselves, they might notice the effects of their actions. So if they spill something, they notice that they did that. They may not know how to fix it or how to change that action, but they notice that something has happened there. And they can follow one-step direction with cueing. So a lot of our residents in this middle stage may be in the memory unit, they may not be. They may still be out and not into that unit yet, but you're starting to see some changes where maybe it's time to go into more of a structured environment. But a really important thing to remember is that one-step direction following is very, very important. They're not going to remember if you walk in and say, good morning, it's time to get dressed, what do you want to wear today, and what would you like for breakfast? They're not going to remember all those things. So if you just ask them one thing at a time and wait for that response, you will have much more success in caring for them. And early stage, the developmental age comparison here is 4 years to 10 to 12 years is what that is showing. So these are our residents that maybe just moving here, or they might be living in the assisted living. So these are our residents you're just starting to notice, they didn't do that before, or they forgot to comb the back of their hair this morning, or it sounds like they're having trouble managing their money, or there's some things that are starting to change with them that you're starting to notice. But they're still able to follow routines, learn some new things. This is just kind of that beginning stage that we all see here. Yeah, Bethany. And then I'm not going to get into the rest of this because these mild cognitive impairment and then independent, so those would be the 6 that the therapist talked about. They typically are living on their own yet, so we're going to move on from there. So that was hopefully just a little bit of an overview of the stages of dementia. Does anybody have any questions about that? Does it make sense when I talked about end stage, late stage, middle stage, and early stage? Can you think about some residents that you're working with that a lot of those things make sense? Okay, good. So now we're going to talk about how do we communicate. So how do we communicate with someone who has dementia? Thinking about some of these stages that we just talked about, thinking about some of your residents. But in addition to that, I want to talk about 3 words: attention, processing, and memory. Those 3 words are some of the biggest areas of challenge for our residents with dementia. And so those are some of the things I want to talk about as we communicate with them. So when we're talking about processing, does anybody know what processing might mean? So processing is when you take in information, so you're hearing me speak to you, and you're putting it in your brain, and you're saying, okay, that kind of makes sense. Or if I say, good morning, it's time to get up, you process what I just said, and you follow my direction, right? That's processing. Processing time with our residents with dementia is significantly increased. So one of my biggest tips to you all is give them time. Give them time to process what you've said. It seems like forever, but 10 to 20 seconds of wait time might be key in getting them to do whatever task you're asking them to do that morning. So if you come in and you ask them to do something and they're immediately resistive, they're probably not processing what you're asking them to do. We might need to either wait or figure out a different way to communicate that to them. So that is one of my biggest suggestions, I guess, because if you are kind of rushing through your day and kind of forget to stop and wait, you may have to call someone else to help you. You might have to tell the nurse, oh my goodness, they're resisting what I'm asking them to do. What do we do about that? And maybe just waiting is enough. I've told this story before, but I see a lot of new faces in here and I want to tell the story again. When I took this class, somebody shared a story about a resident that they had. His daughter came to see her every day and they had a wonderful relationship. And every time the daughter would leave, they would say, I love you, and I love you too, Mom. And as her dementia progressed, the mom stopped saying, I love you too. And the daughter, left sad and, wondering what was going on. And so one of her caregivers had taken the Dementia Capable Care class and understood the importance of wait time. And so she was in the room that day, happened to be there when the daughter was leaving, and the daughter said, I love you, Mom, and the mom didn't say anything. And the daughter left and was sad, and about 10 to 20 seconds later, the mom said, I love you too. So the caregiver ran off and found the daughter before she got in her car and said, I just want you to know she's still saying it. It's just taking her a while. So I think it's just a really powerful, every time I tell that story I get goosebumps. I think it's just a really powerful demonstration of waiting and giving them that time to process. So as we're talking about processing and wait time, what are some other things that you think we could do? If they're having trouble understanding what you're asking them to do, what do you think you could do? Show them, yes.
Yeah. Pull out the chair, pat the chair rather than keep saying sit down, sit down.
Yes, yep, kind of a demonstration, Sit here. Yep, cues, physical cues. Yep. Somebody else said something, or was it the same?
The same.
Same, good, yep. And I kind of said it earlier, but short sentences, condensing what you want them to do. Stand up. Or if stand up doesn't make sense to them, time to go. We need to make our conversation make sense. If I said to you, stand up, you're like, well, why? Why do you want me to stand up? If I said, let's go, that's a different way of communicating with someone that maybe isn't understanding where they're at that morning, that afternoon, that evening. Where do you want me to go? What are you going to do with me?
It's a little bit like foreign language.
Yes.
You know, if you were to be in a foreign country, you have to use Panamines to get to where you want or what you need. And they don't always understand. We speak quickly.
Right, absolutely. Yep, we speak quickly, which is very important. And I think sometimes we have to recognize within ourselves as, am I comfortable with waiting? Some of us like to speak a lot and quickly and just are uncomfortable with some of that silence. And I think we have to look within ourselves to say, is that me? And do I need to be okay with waiting and taking that time and, just having that silence for a few seconds? So some of that introspective stuff as we care for our residents with dementia is really important. Great, you guys got it all for processing. Short sentences, visual demonstration, cues, and then that 10 to 20 second wait time. All right, memory is another word I wanted to talk about. So as you all know, our residents with dementia struggle with memory, right? Is it their short-term memory or their long-term memory that they struggle with? Short-term memory, right? So long-term memory, they remember what they did for a living. They remember their kids' names usually. Now it depends on the day. Sometimes their kids may be young children, and some days they may know that their kids are older and have their own family. It just kind of depends on the day, right? So long-term memory is really important when we care for our residents. It's good for you guys to get to know your residents' history. What did they do for a living? Who are their children? Did they have a spouse? Is the spouse living or not living? One thing, please don't remind them that their spouse passed away. It just makes them grieve all over again. So we don't want to lie and say, yep, they're coming in an hour, when they're not. But we don't want to remind them because they may think they're 25 years old that day and you just told them their spouse died, right? So it's really important to not tell them that.
What's a good option for?
Good option would be,
I'm not sure, or?
I'm not sure. You could even say, I think he's at work today. Yes, we're not telling them the truth, and that feels yucky to us as caregivers because we don't want to do that. But think about how she would perceive that. If we told them over and over, every day they were reminded that their spouse passed away. So I think it's better to just say, I'm not sure where he's at right now, or I bet he's at work. He's such a good worker, and talk about some of those things, and maybe if you know what his job was, you can talk about what his job is, and then try to redirect and move on to something else. The faster you can get them off that topic, the better it will be.
If the resident approaches us, we have a couple of residents here that might approach us and say, is my spouse dead? Is my husband dead?
Yeah.
And it's like, well, yeah, they are, and then she just goes, oh, okay.
Yes, I think that is fine. That because her level of awareness at that point is a little bit higher than, where's my husband? I need to go home. That kind of, that kind of level is they've got a little more understanding of what's temporal, what's going on in the moment. So yes, if they ask you, if they ask you every day and they forget, it may be okay to say, I don't know. But in that situation, I think if it's kind of a one-time thing, like, okay, I kind of forgot, is he gone? And you say yes, I think that's fine. If it's a repeated question, then I think it may be okay to redirect that question. So, thank you. So with memory issues, one thing that is really important is we need to use nouns. So when I say nouns, I mean, let's not say, let's go sit over there. Or did he come today? Or he, she, there, those kinds of things. They don't know what you're talking about. So did Mike come to see you today? How is Mike? Those kinds of things. Or let's go for supper. Would you like to have milk or water for supper? And let's sit in this chair. You want to be very descriptive when you're talking with residents with dementia because you don't, they're going to forget when you don't use really descriptive words. So that's one thing I wanted to tell you. Close-ended questions, I just kind of said it, but in the morning, would you like to have orange juice or apple juice instead of what would you like to drink? Because if they wake up in the morning and they don't know where they are, they don't know who you are, and they sure don't know what's for breakfast. So asking them those close-ended questions. Would you like to wear this shirt or this shirt? Not what would you like to wear today, because they probably have forgotten what's in their closet. So using close-ended questions. Short sentences, again, are important. Step-by-step instructions. It's time to get up, and then you help them get up. Would you like to wear this or this? And you do that task. It's time to brush your teeth. Instead of, let's get up, let's go, we've got to brush teeth, we've got something to do today, let's find something to wear. They're not going to remember those things, and it may increase the anxiety and the fear of what's going on that morning. So keep things real short and simple. We want to teach our family realistic expectations. Sometimes family members come in and don't really know what to say. They don't know how to communicate with their loved one. So they're going to say things like, what did you eat this morning? What did you have for lunch? Have you had a bath today? Did you do any activities? Our residents are not going to know that. They're not going to remember. And oftentimes they're going to say, nope, haven't had a bath in 2 weeks, right? Which is not true. We all know that that's not true. But then family members might go, oh, what? You haven't had a bath in 2 weeks? So we need to help them set realistic expectations for their loved one's memory issues. Yes, they've had a bath. We're taking very good care of them. They just don't remember. And helping them to say, if they say, Jill hasn't come in for 2 weeks, I can't believe it. And the brother says, oh, Mom, I'll make sure that she comes in tomorrow. And just kind of letting it go instead of, making that worse. Yes. Okay, we're going to move on to attention. So what happens to you guys if you need to use the bathroom, you're hungry, you're bored? What happens? What did you say?
Get agitated.
Get agitated? Yep. What happens to you if you're sitting and listening to me and you really need to use the restroom? Distracted, right? Or your stomach is starting to rumble, right? Or you're finding what I'm saying boring, right? We start staring out the window, not paying attention, right? Our level of attention drops. So same thing with our residents. If they need to use the restroom, if they're starting to get hungry, and you're asking them to do something, their level of attention to you is not going to be where it would be if we've taken care of those basic needs for them. So just be mindful of that piece of it, and think about how you would feel if you really needed to go to the bathroom and you just weren't able to do that, right? Your level of attention goes down. So when someone has attention issues, which most of our residents do, one of the best things you can do is try to maintain eye contact, right? Because if I'm looking right at you and we're talking, you're going to look at me and you're going to listen more, right? If the teacher comes over and stares at you and says, so what is 4 times 3? You're going to go, and you're going to pay attention, right? Where these guys over here might be going, what did you say? Right, so try to maintain that eye contact with your resident. It's really important. Leading with their name, always using their name, right? If I say, Jill, it's time to get up, or Jill, it's time to go have breakfast, or Jill, let's go to an activity, I'm going to listen to you. I'm going to pay attention to you, right? Or Jill, let's stand up and let's go over here. Or Jill, how are you feeling today, right? It just feels better when someone says your name, and you're going to keep their attention when they do that. Now, on the flip side, when you come in and work with them, do you think they remember your name? No. So it's really important for them, for you to always reintroduce yourself, always. Even if you've worked with them for 5 years, right? And you know everything about them, and some days they know you and you guys are best friends, right? But if you come in that morning and they don't know you, make sure that you say, good morning, I'm Jill. It's time to get up, right? So that's one really important thing that I'd like you to do. And let's see, eliminating distractions. right? So if you're in the room and you want something to happen, you want them to go to the bathroom, you want to get dressed, whatever it may be, and the TV's going, or the radio's going, or maybe your roommate is having some struggles at the moment, or whatever it may be, you've got to try to eliminate some of those distractions first. Shut off the TV, turn off the radio, help the roommate, whatever it may be. Then you can try to get your residents' attention, right? So just like the rest of you, somebody just walked by, I don't know if it was with a cart or something, and I saw many of you look out that door, right? Which is normal, and it's normal for our residents too. When there's a noise, when there's other distractions, we pay attention to that versus what's going on right in front of you. So try to maintain that attention as best as possible. All right. Okay, we're going to go on to behavior. One really important thing that I need you to remember today is behavior is communication. They are communicating to you with a behavior. It may be a good behavior, like a smile or a laugh, or it may be not a good behavior, and it may be a hit, or it may be a yell, or it may be something else, but they're communicating with you. Sorry, I need to find my slide here. Okay, so behavior is communication. Their cognitive level impacts their behavior. So we were talking about the end, late, middle, early stages of dementia. People in early stage dementia may swear at you, may yell at you, may call you a name, because that frontal lobe is deteriorating. That's what we call the filter, right? That filter is changing. Somebody with middle stage dementia may start hitting, may start what other behaviors that may happen, okay? Somebody in late stage dementia is probably not going to be as physical in behaviors, and it might be more of a yelling out or crying, something like that. End stage, you typically don't see behaviors, so the behaviors will change depending on their cognitive level. They often communicate through negative behavior. As we talk about the developmental stages, this is why I talk about this, comparing the developmental stages to our residents with dementia. Because if you think about kids, and you think about a toddler, right, which is kind of that middle stage to late stage-ish dementia, how do they communicate with you if they're angry? Usually hit you, usually yell, you run away, scream, cry, because they haven't figured out how to express that emotion appropriately. Our residents with dementia, because things are changing in the reverse, they're losing that ability to express that emotion appropriately, okay? So they're expressing it to you, and I'm sure they would love to express it to you in an appropriate way, but they can't anymore because of the changes going on in their brain. Some of the examples we see would be sundowning, right? I'm sure you've seen that. What we call refusal. Refusals is sometimes I like to challenge. Are they really refusals? Or is it because they don't understand what we're asking them to do, and we need to change how we're communicating, right? It might not really be a refusal. If it is, we'll talk about that. We can try again later. But let's try to change ourselves and how we approach it first before we just say it's a refusal. They're refusing to participate in an activity. But maybe they don't know what it is. Maybe they're not understanding where they're going, who you are, why are you taking me somewhere? We have to start with those small steps first before we can get to participation. Perceived negative behaviors based on an unmet need. We'll talk about unmet needs here in a minute. Behavior problems usually arise out of several things. Pain. If I have you sit here and tell you you cannot move a toe for 15 minutes, you're not going to like me very much, right? Because your bottom gets sore, your back gets sore, something is you're going to feel like you need to move. And so when you start to be in pain, You're not gonna pay attention to what's going on. You're gonna start getting angry. You're gonna start, there's gonna be some issues. Same thing with their residents. If they're in pain for any reason, they may communicate that with some sort of a behavior. Fear, fear, one thing I want to talk about with that is think about bathing, right? Bathing is a very personal thing that we do, right? So if you're a caregiver and you're helping somebody take a bath and you don't know them, they don't know you, particularly if it's a man giving a bath to a woman, there may be some issues there. If there's been abuse in her past, we just don't know always what has gone on in the lives of our residents, and so we need to be very aware that if somebody's starting to have a behavior, maybe it's always when you take a bath, or maybe it's always when you're doing pericares, or maybe it's always, is there a pattern to that behavior, and could it be caused by fear? And so we have to talk to each other about that, talk to family members about that, and see, try to figure that out. An unmet need. Sometimes our residents, a lot of times, are only touched when you're doing cares. Maybe they just need a hug, right? Maybe they need a handhold for a minute. Maybe they need some sort of a touch that's not a care being provided to them. So some of those unmet needs, especially if they don't have a lot of family coming to visit, or people feel like they can't touch them anymore, try to recognize that in your resident. Loss of sense of self, right? That's going to happen as the stages progress. They know that their memory is changing. They know that they can't do things the way that they used to do. It gets very frustrating and they get very sad. And so our job is to help them do what they can do to their best of their ability and keep those remaining abilities as positive and as interactive as we can. Inappropriate expectations. 90% of behaviors are caused by us. I think that's a test question. 90%. So that's kind of a sobering statistic, right? 90%. So how do we change that? How do we change how we interact with our residents to try to prevent some of those behaviors? Okay, here's some approaches, and I wish I had kind of a magic pill for this behavior do this, this behavior do this, this behavior do this, and I don't. Because every resident is different. Every resident has different life experiences, every resident has different interests, every resident has different ways that they express their emotions when they had a typical brain, right? Some people were a little more verbal, some people were a little more shy. So everybody is different, and I can't do that. But what I can do is I can give you a lot of tools to think about. So number one, if you can, come back later, okay? Let's just give that a try. Incorporate their interests and routines. If they love to sing, sing with them. Sing while you go to the shower. Whatever it may be, try to incorporate those interests and routines. Gain their trust and agreement. If you come in the morning and you just wake them up and you just start doing cares, they're probably going to resist. They don't know who you are, why you're touching me, right? So it's really important, sorry I keep picking on you, but it's really important to just get down eye level to eye level and just say good morning. And just give them a minute to respond, right? Give them a minute to respond and just be warm and caring. You know, have a look. You may have had a really bad night or a really bad morning or whatever it may be, but when you come into that room with your resident, they need to see that you care about them. Because if you're coming and going, good morning, it's time to get up, let's go. Like, I really don't want to be here today, right? We all have days, but our residents need to see that we're there for them. So gain that trust and agreement. So good morning, I'm here to get you up. Okay, it's time to get up today. I'm Jill. Sorry, forgot that. I'm Jill. It's time to get up this morning, okay? And just see, even if they can't say okay, that eye contact with you is going to show you that they're ready. Provide as much control for them as possible. You want to wear this shirt or this shirt, okay? Reduce stressors as much as possible. If they're at a table with other residents and maybe that isn't going so well, maybe consider a move to a different spot. Check for pain, always check for pain. You just never know Help the resident develop relationships with you or others. They really want to get to know you. They want to know about you. They don't need to know problems, but they want to know, do you have kids? Do you go to school outside of work? What do you do? And just develop some interest. Maybe somebody's a teacher and you're in school, and they would love to talk to you about what grade they taught or what they did. Use that long-term memory to make those connections with your resident. Minimize time left alone. That really can reduce behaviors because, I mean, my grandfather, who's now 100 and does not have dementia, was sitting in his room by himself and decided he was going to get up and go hang up his belt. Fell and broke his arm. You know, it's things like that where, not that I'm saying he needed to be supervised all the time, but they do happen, right? Things like that happen. And so the more activities we can provide for them, the more things that they can do, the better. Listen and support. If somebody is having, they're crying, they're having a bad day, something's going on, just say, I know it feels really scary when you don't know where you're at. I understand that. We're here to help you. Support them, okay? Sometimes we're so wanting to get our jobs done that if we can just take a minute or two to support them and listen to them, you will get a lot more done faster. Anticipate and meet needs. So if you know 4 o'clock is a really bad time for that resident, find something for them to do at 3:30 or 3:45. Get them engaged in activity before a behavior may start at 4 o'clock, 4:30. Engage in valued activities. Okay, I need to stop because I'm over my time. Let's go, do you want me to do the quiz?
Yeah.
Okay,
That's great.
let's do the quiz. I have to look at somebody. All right, number 1. Those with dementia are better with verbal than nonverbal communication. Is that true or false? False, yes. So they're better, that's okay. So they read your facial expressions, your mannerisms a lot better than what you actually are saying. Number 2, strategies for communicating with someone with processing impairment are B, C, and D. Very good. A resident with dementia may not remember who you are, but they remember how you make them feel. True. When working with a resident with dementia, I should. Yes. Yes. Yep. 5, behaviors such as hitting and yelling are because the resident doesn't like you. False. List 2 things a resident's challenging behavior may be trying to tell you. Pain, fear, frustration. Very good. 90% of behaviors may be triggered by the caregiver or the environment. True. The best way to prevent falls and behaviors is a healthy schedule of activities. True. Very good. Any questions? All right. Thanks, everybody. Have a good day.
Thank you.